You're now live.
Right, so we're now live. Welcome everyone to our FBS chat. We're really lucky today. We've got two wonderful people with us. Kidge, who we'll find out a lot more about quite soon, and Jonas, who we've interviewed before. And it's really nice to have you both here. So, Kidge, over to you. We always fascinated about how people started on their solution-focused journeys and how they use it in their work. So, when did it first ring a bell for you, or when you knew this was the right way for me?
Okay, I guess I would like to go way back to. Is that me making that noise?
No, we can hear that.
Okay. Going back to actually probably when I was doing my A-levels, and I did history, English and biology. I always liked the science and the arts, which people kind of tended not to encourage that you did. And then years later, I was teaching English, and I'd done a linguistics course. I heard somebody talk about a job that was kind of speech and language therapy. So I then went on to do a postgrad course in speech and language therapy, and that combination that I think I was saying of kind of the arts and the science. It's, there's a lots of stuff about anatomy, physiology, neurology, but then there's also child development, there's linguistics, phonetics, there's counselling. And so I started working in the north of London, and in fact I started working with older people, and I kind of felt that despite the kind of, great training at City, I didn't really have the skills to sort of help people in exactly the way that I wanted, because especially with older people, you'd have a differential diagnosis of kind of dementia and aphasia maybe, and where with the kind of assessments I had, which ones did I do? And a newly qualified therapist, it was really hard. And then one day I was at a big staff meeting, and I heard somebody give a 1-hour workshop on solution-focused brief therapy, and she went straight in and we had to do the miracle question on each other. And I just thought, right, that's it. That's what I've been looking for, because it's getting people to describe what, and I know this will be really, really useful to me. So I started reading everything I could find. This is 1997. And the following year, I was lucky. I moved from North London to South London Hospital, and I got some training, 4 days training at Brief. And then I did every course I could. I did, I saw INSU in 2000. Later on, and in fact, I started going to the EBTA conferences. I think I went to 9 altogether over the years. And my first one in Amsterdam, I met a whole gang of people, really nice group of people, and I was completely. And I remember Raya said, "Hey, come and join us," and really, I was thinking how lovely to be part of this group. And Stevens, who were in Amsterdam. In fact, I did a really embarrassing thing. I went up with Steve and I said, "I want to thank you for bringing this way of working into my life," which, of course, he didn't know how to respond to. I don't really know how you do respond to that. But anyway, I felt compelled to say, this is this wonderful thing that's made such a difference in my work. So, ever since then, I've been doing it both kind of up until 2016 in the NHS as a speech and language therapist, but also outside of that, with just counselling, coaching, giving supervision to people. So I guess it was that combination of very kind of precise work that we do as speech and language therapists, interested in the brain and what's happening in language. I've always had, in speech therapy, you do a lot of, you analyze language in great detail. And so, of course, there's that thing of language of solution-focused therapy that I love. And, at the same time, working within the medical model in hospitals, you're surrounded by all this sort of this science, this knowledge, which of course is hugely helpful, but it does need that other bit. It does need all us allied health professionals, and you know, there's a lot of us, occupational therapists, physios, dietitians. I think we should all be trained in this. I think it's really important that we have this training. So that was a long stuff. As you can see, I'm still very passionate about it after all these years.
Yeah, and it comes through, and totally agree with you on, because we've met many solution focused practitioners, and it is a wonderful bunch of people and very welcoming. And you've met the two founders, which we haven't. So I know you've spoken briefly, you had a chat with Steve. What was that like?
Well, I'm really sad because I missed the last workshop he gave at Brief, which I could have gone to, and I remember Harvey saying you should come to it if you can. But I mean, I used to, in the days when it was all VHS videos and cassettes, it was more actually Insu that I would listen to. I'd be doing my ironing and I'd listen to the cassettes over and over. So rather bizarrely, I started getting this thing of saying "wow" all the time, which was a legacy from Insu. So I suspect in the beginning it was more Insu that I kind of that thing of bringing out people's resources. I really sort of identified with, and then sort of subsequently, I suppose, reading more and kind of over time the thing of Steve of. I don't know, that ability to step back, to listen. You know, they're obviously both great listeners, and learning that, and particularly in speech and language therapy, where you really have to listen quite hard. In fact, often you have people with very, very little speech, very little language, and so you're having to make do with very, very little. And I think both Steve and Insu showed that thing of making do with very, very little and then developing that and getting description from that. So, yeah.
Jonas, do you have a question or an observation?
You know what I've been doing when I've been listening to Kidge? Yesterday there was a workshop with Guy Shannon. He was doing something for John Wheeler, and he was talking about Richard Rorty, and he ended the workshop with such a nice exercise. So I thought I'd continue it here. And then if you listen to somebody, pick out the words and then make it into a poem. So I've been listening to Kidge now, and this is what I got. You want to hear it?
Yes.
Yeah.
Teaching English, arts and science. Older people, really hard. 1 hour workshop, useful to me. Lovely to be part of a group. Speech language therapy. Doing ironing, saying wow all the time. Making do with very little.
Wonderful.
Oh, brilliant.
I didn't know you were such a poet, Kidge. It's all in you. It's all from you. It's amazing. Wow. What a lovely story.
Yeah. Fantastic. I mean, I
go on.
So I was just thinking that thing of being inspired by words, but also by the kind of the visual thing that last week I was talking to a colleague who was in fact a speech and language therapist, and she was talking about somebody she'd met who had very, very little language. And in fact they were I think it was he was describing how he was feeling, and it was sort of like this. And sometimes we have to work backwards from no words to co-constructing words. And so they came up with this thing that this person felt, and I got it, shut in, that's right, that they felt very shut in. So Emma said, well, what would be the opposite of that? And he went like this. He raised his arms like this, which was just sort of wonderful. And then so they said, well, together they worked on what does this mean? And they came up with the word excited. So I just thought, isn't that wonderful, just that one word excited, that obviously being respectful of people who have been through a very big thing like a stroke, of the difficulties, but at the same time that person could imagine being excited and what that would look like in their lives. So yeah, and it all came from this sort of these movements, this bit. I'm going to do a lot of this now, I think.
We'll all be doing this before we end. I'm already doing it. I can't stop.
Hey, hey.
Oh, what a great story.
I've got a question, if that's okay. Working with speech language therapy, and you work a lot with older people, and I know you work with people who had strokes and difficulties and stuff. I'm fascinated by that. What have you learned from your clients that you're most proud of?
Oh gosh, I think that ability to adapt, because these are life events, and in that sense these people are kind of experiencing loss that I can't take away, and it's normal. And so in that sense it's people need to go through that process of experiencing, acknowledging what they have lost, but at the same time that ability to think about change in a way that they want, and how, even though sometimes being very restricted, that they can, especially with solution focused conversation, notice the smallest changes, I think is so impressive. And and create identities that have to be very different, maybe. I mean, still the core of themselves, but that day-to-day living might be very different to what they had before, which of course is something we're all experiencing at the moment. But no, I mean, I think it's very humbling. I mean, the work that Sarah Northcott's been doing with profoundly aphasic clients, and you would think that this solution focus thing wouldn't work with them, but it does. And I think it underlines that thing that never be afraid to ask the questions, because you will be amazed at how people do get them. You might have to rephrase, repeat things if it's somebody with dementia, but they get this language, and they get this mindset. It's of course not just about the questions, it's about what we as clinicians how we can think differently, and that who we invite into the room. I love that analogy of the sort of, we invite into that room that person who is resourceful. So I think I always find all of these people are unbelievably resourceful, and yes, so I've obviously learned a huge amount from them, as I'm sure we all do with all the people we see.
Yeah. And
thank you. That was a lovely answer.
Yeah. And
you're going to get lots of repeats on that. People are going to be looking at that piece over and over again. That's so much.
Yeah. Aren't you nice?
I mean, going back to before, when you did your assessments in the way that you did before then, and obviously the way the conversations have changed now, what kind of, how's it made a difference to your clients, do you think? I know you've touched on that already, but just those questions and that.
Yeah, well, I mean, you've got assessments is one of my things, actually, because as allied health professionals, we all have to assess. Obviously, that's our job. So, a physio assessing mobility, occupational health, activities of daily living. But I think it's where and how you do that assessment, because the people, the speech and language therapists all say to me, how can we integrate this with what we do? We've got to do a certain sort of this. How does it fit with it all? And I think, in the past, I would have gone in, I would have done the assessment, and then maybe we'd have a conversation. But I mean, the real learning point was, at one point I did an assessment, and I was sort of beginning in solution focused practice, and I said, oh, look, it's time to go up for lunch, which was in the hospital. How has this session been useful? And the client said it's been no use whatsoever. And
wow.
They were absolutely right, because it was so many assessments that are just highlighting what they can't do. And I've never found that. So I would sometimes try to, as we went along, say, pop in a solution focused question if I could, if that was allowed within the kind of, formal assessment thing. But I think now I would make the assessment come a little bit later. I think I would start off with, what are your best hopes? Try and get a description of that and progress made up to now. So I think it's about how I package what I do. And I noticed the police force at the moment talk about the 4 E's, which I think is I've written it down because I thought it was, I just read it. Oh, that's right. So we have to engage with people, we explain to people, we have to encourage, and then we have to enforce. And I think as allied health professionals, we do have to do some explaining, but it's when you do that explaining, I think I'd like to think that we first of all do that engagement, and then that encouragement, and then if there's explaining that needs to happen, that comes a little bit along the way, rather than going straight in and saying, oh, I see you come for this, and explain what you think the problem is without hearing their voice. So it's about giving them voice, and I think they really appreciate that. That engagement is there from the start, which is fantastic. Yeah.
And focusing on what they can do rather than what they can't has made a massive difference.
Oh, absolutely, yeah. And very often you find that people, rather than me giving strategies, they're already doing half of them. So I can say, wow, I've noticed while you're talking and describing stuff that you've mentioned that. Isn't that great that you're already doing that? Because that's something I would recommend to you. So, people feel totally pleased with themselves. And that can happen on things that are perceived as quite sort of complex subjects. I mean, often people don't realize speech and language therapists are involved in assessing the swallowing because of all the anatomy there. So, it's quite in fact, particularly during the last few months, a lot of speech therapists have been involved in intensive care, looking at the whole swallow mechanism. I mean, maybe not in that setting, but I mean, as outpatients, people would come to me and say, I've got problems with my swallowing, which is a hugely debilitating thing that you can't be enjoying your meals in the way that you want. And instead of asking, okay, so tell me about all the problems, there was one time when I was running a group with a whole lot of Parkinson's patients, and they often have problems with swallowing. I thought I'll chuck all those questions, and I'll ask them to go into to groups, pairs, and say, what do you enjoy eating? When was the last time you had a good meal? And they started describing, a particular moment. And I said, what were you doing in those moments in that meal that enabled you to enjoy it? And then, again, they would come up with things that they were doing and how they were adapting, rather than me saying, these are all the problems you're going to have, and the condition gets worse, it's going to this, which is kind of pretty depressing, really, because, we can't necessarily stop these things happening. So, yeah, it's really restructuring what you do. And I say to speech therapists, but I mean, I've worked with physios and trained lots of different allied health professionals. I'll say you're still doing your job, but you're doing it even better. And what you'll enjoy about it is you're going to feel much more creative, and you will get better results. The outcomes will be so much better because it's so much more is coming from the client. Which has to be a good thing.
Wow. Jonas.
Wow. I mean, your pioneering work is so impressive. What would I like to ask you? What would you like to? What would you like me to ask you? What question are you hoping to get?
Oh, gosh, that is a really hard question. I don't know really. I think maybe there's, but you wouldn't be asking this question of, you know, do you have to ask different questions for these people, for example? And I would say no.
So what question do you really want?
What do I really want? I suppose, well, I don't know, even hearing from you guys, and you probably come in contact with other people working in hospitals, and have you noticed similar things? I mean, I'm guessing you probably have, that resonates with what I've been saying.
I think, am I on? Yeah. Yeah, I mean, especially the, you know, that sort of client as expert role, and what is it that you're doing, and those exceptions, and how can we make those more the norm rather than the exception, and what you were doing at that time. And I was gonna ask you, you know, because you said earlier when you used to ask your clients after an assessment, so, you know, how did you find the session? And they said, well, absolutely useless, really. You've just told me, you've just given me a list of the things I can't do. Thank you very much. So how do you think they would respond now, or how do they respond now after a more solution-focused interview?
That's a nice question.
Nice question. So yeah, and it's also because it's sort of, I know it's controversial asking at the end of a session, how has this session been useful? Because a lot of solution focused practitioners say, how can they know? They won't know until they go out there, do what they're doing. If they make the question, if they make the difference, then come later on. But I still like asking it, and I think it might be to do a bit with maybe some of the people I've seen, because, you know, if they do have memory problems, for example, then thinking back over the session, having something that they can walk away with out of the room seems to be quite useful. And if they initially say, well, I don't know, I'll say anything at all, anything you said.
Who's coughing?
Yes.
We should put Aisha on mute. Sorry, kids. Go on.
Yeah, so, you know, anything that they said that they can walk away with. I like that, and people often do say something like, "Oh yeah, I was really surprised I said that." Or, for example, if we've done a scale, I mean, I'm quite a fan of scales, and I know, again, not everybody uses them now. They'll say, "I can't believe I put that number on the scale," and that's, you know, that's quite interesting. Their scale, and, you know, there must be a reason that they put themselves where they have. So yeah, scale seems to be useful because they might come back and talk about that scale again, and obviously that doesn't matter. And in themselves, the numbers don't mean anything either. And get hung up with numbers anyway. But Joe, well, that's fine.
Yeah. And it is a brave question to ask at the end of a session. I don't do that enough, I don't think. I think I should do more of that, because I want to know what's useful to the client, not what's useful to me. It's nothing to do with what I found useful. So that's a brave one. It is one that I'm gonna keep trying to do.
Well, I think you might be surprised, because I mean, I know lots of research has been done in this as to, you know, people go into the therapy session, come out and say, completely different. We had two different conversations that had, and yet they both in the same room together. I mean, one time somebody said to me, it's been really useful talking about Parkinson's disease. Well, we hadn't. We were talking about her life living with Parkinson's, but not, I hadn't been giving her a whole load of stuff or advice specifically on that. But if that's what she felt useful, then I'm fine.
I've got a question that's been mulling around now for a while. You're practicing solutions focus and spreading solutions focus in hospital environments. I mean, I suppose it's the same in Sweden as it is in the UK, that they're very, hierarchical, very problem saturated. There's a lot of, professional boundaries. What has enabled solutions focus to grow in the hospitals where you work, and what have you been doing to help that?
I think it's hard. I think I was lucky to be in a department where we were all trained, which makes a difference. Mm-hmm. And so we were able to go up on the wards and, maybe have conversations with clients and then we'd report back, because you'd be talking to the medical team and they'd be interested that maybe we picked up stuff that other people hadn't. I think when you do multidisciplinary teams or case conferences, and you'd go through, often with families present, you would go through different members of the team, and we would talk about all the strengths and the skills that patient had, which again was sort of, so I think it's that thing of you just do it, and people pick up that something is happening. Even in the medical notes, I'd write their words rather than mine, because I always thought that was far more interesting, rather than me putting it into sort of jargon that, speech and language therapy, like every other profession, has a whole lot of jargon stuff that we use. And so I think it's about kind of, the working underground doing it, but also shouting it from the rooftops. I think as much as I could, that was the harder bit. If it was sort of possible to get a slot where I could talk to some of the consultants, there were a couple of consultants who were quite keen. That's hard though. That's hard to get access to the doctors, the nurses, so unbelievably busy. They would, one time I was given a slot, but, they were kept on being called away and sort of going in and out of the room. But just last year, some nurse managers asked me to do some training, and that was quite interesting because that was on supervision. I was involved in a project in 2012 on this 10-minute talk thing I did, where we were doing supervision, and very short supervision, especially with this thing in mind that in acute hospitals you have so little time. And I think it was sort of following up from that much later, as I say, last year, the nurse managers called me in and said, well, how can we be doing supervision more effectively with some of the junior nurses? And what was interesting was that they were saying, look, we have this allocated time, but the nurses aren't very keen to come in and have these conversations because they feel they have to discuss issues. And sometimes they say, well, I haven't got any specific issue, but, here's this time and it's all a bit awkward. But what about with a solution focused hat on, talking about something you've been pleased to notice, that is working well? And then suddenly the whole thing is completely different, that can lead into, maybe that's something I would like to tweak a bit more. But if you start from this thing of inviting people to think about supervision differently, I think supervision is quite a key thing because we all have to do it. And I think it's a lovely way to start incorporating the questions. So if people aren't lucky enough to get much training, I always say to them, look, practice it in supervision. We're meant to be doing peer supervision. Practice asking each other those questions because it's really, really useful. And I always did it with students. Obviously, we had students coming in on placement. And the first question I'd ask them on the first day is, what are your best hopes from this placement? And usually, actually, they would talk about, I'm not going to feel so scared being in a hospital, because they found it really scary. And every week I would keep asking, so for this week, what are your best hopes? And they would very often say, I don't see how this fits in. I want lots of all the clinical stuff. And at the end, they would always say, I've got it. I can understand how you go up and talk to patients, and you need some sort of language and some way of engaging with them that this gives us. So it's hugely helpful to newly qualified or students to sort of get there more quickly, because otherwise it can be a long process, I think, to learn to talk to people in sometimes very sensitive areas. I mean, we were seeing a lot of people in palliative care, and they would say, I got no training in how to talk to people who are dying or families who are experiencing these awful situations. And I'd say, well, just keep asking the same questions, because they will tell you they're living with it. It's not that you have to, it's not about you anyway. It's ask them, what are the best hopes for the time, that they have, and they will tell you, and be led by them. So I think that the way that we learn from clients is something that is so important, particularly in hospitals. And I think, doctors, obviously who's so wonderful, can often lack that training. The bedside thing of in my book, in the second edition, I included a conversation I heard. I was sitting in the bed next door, and the whole medical team were there. Sorry, it's too much talking.
Not for us as listeners. This is great.
And the doctor was trying to kind of compliment the patient, saying, isn't it great that you're sitting out in the chair? And patient said, no, it's not. I'm in great pain and I want to go back to my bed. And it was just a little short conversation. I thought you could just tweak that. It didn't have to be very different. Even just saying, are you pleased that you're sitting in that chair? Because these are the steps that we're talking, the small steps we're talking about in hospitals. And even if they say no, but the physiotherapist told me to, or the occupational therapist told me to do it, then, already you're getting insight. This patient is listening to people, is appreciating and taking on board things, even though they're in pain. And then I thought, well, what about just saying, suppose we have this conversation tomorrow, which they might, because they're going to come round again tomorrow. What do you hope to be telling me? So they're not very difficult questions, but they're embedded in that solution focused thing of being curious and kind of listening to the client again before you start moving in and talking with the other doctors and saying this patient has got such and such diagnosis and all the rest. It doesn't take a lot, I think, and it's about believing that just a few questions can change a whole conversation.
It's really because we was speaking to quite a high person in social care, children's social care, and she's very much into the solution-focused way of working. And it was, how is it not just affecting you as a practitioner, but your team? And she was a bit like what you're saying, Kidge. It was almost like solution-focused by stealth, just having those conversations, having those meetings. Because I know we absolutely love the NHS, and the nurses are fantastic, especially we're all appreciating them even more now. And I guess what is holding it back? So rather than it having to be done stealthily or from behind, when are they going to embrace it fully, do you think? Or is it because there's lack of research? What's holding it back in that arena?
I think the research is one of the things, and we all know how difficult it is to do solution-focused practice and research that's recognised, which is why I think Sarah Northcott is doing such fantastic work, and I being clinical supervisor for her Sophia project. And in fact, I'm writing another book, and we're doing it together. So that's really, really exciting, because she can bring in a really nice sort of academic slant on it, which I'm not so good at. But I think, you know, it's training. It's back to universities, back to where, you know, when I was training to be a speech and language therapist, the counselling element was just one sort of small module, and I don't even think it should be just even seen as that. It's about how to communicate with people, because as we all know, this is conversations we can be having with anybody, and not to feel you're a specialist in death and dying, or specialist in dementia, or yes, of course, if you've got expertise in those areas, that'll be, you know, it'll be important. But you know, one time and this was a while back, the city students got me in their lunch break to go and do some training. They were so desperate to get this that they'd heard, I think one of them had been a student with us. So I think training, I think, to be honest, I'm, you know, it has been around a while. I'm surprised that it's not more used. There's the nice guidelines now in some areas in palliative care. So, you know, there's a lot of fantastic people in the UK, you know, Becky Sim, all sorts of people who are using it with chronic pain, Dominic, who with palliative care. So I think it's there, but I just think it does seem to be taking time to be more recognised. Yeah, unfortunately.
And yeah, because you can just imagine, because those short conversations can be so wonderful for patients feeling at their lowest or afraid of what's going to happen next. So just people having those short conversations can be so well, it's empowering. It's definitely an empowering way of working, and we are meant to be more of a strength-based, or we're supposed to be more strength-based, particularly in the social care field. So it should fit. But yeah, I was just curious as to, because it sounds like you've done brilliant work, but yeah, it's taken its while to get through more mainstream.
I had a nice conversation with Eva Persson. She was the person. She and Björn Johansson taught me solutions focus like 20 years ago, and she was saying in the 90s it was much harder to teach solutions focus, because the normal paradigm of the 90s was you're supposed to do assessments, you're supposed to look at what's not working, you're supposed to, you know, be more problem oriented, and it was much more harder to sell the idea of no, there's something else you could be looking at. Whereas now, she was saying it's so the zeitgeist is different. People are more interested into strengths. People are more interested, you know, without knowing about solution focus, there's already an interest or a curiosity of looking for what's working, and not being bogged down in, you know, endless, tedious problem orienting, you know, vicious circles. But there's a kind of a generational shift even. I don't know if this is the same in the UK. Is the environment somehow more conducive for a solution focused message or an approach? Is there anything there that's resonating with how you're seeing things in the UK?
Well, I mean, I've been out of it since 2016, specifically in the NHS. I think the language is there. I mean, since 2001, the expert patient, recognizing the patient is the expert. I think the language is there. Sometimes what doesn't match up is the actual things that are put in to facilitate that. And I think, as I say, it goes a lot back to training. And sometimes I think it maybe is just with, you know, getting us to experience what it's like being at the receiving end of solution focused practice. You know, when they talk about in nice guidelines of this, particularly in palliative care, of respecting people's wishes to have control over their environment, to have dignity. When we with each other answer these questions, we pick up that thing of how respectful they are. And I think yes, I think that's hopefully with a recognition that care needs to be more individual, and that some of the bad practice that have happened over time has lost sight of that, and I think hopefully that is happening more, and I think the NHS also is getting much better at looking at outcomes.
Right.
So and the outcomes not just on measuring symptoms and the physical side, but on the personal recovery. That again, that language is there, but it's how to measure that. And in the hospital we were using outcome measures, Scott and Miller ones that I learned a lot, because it's measuring how people felt for themselves in terms of improvement, and that will help, because people who buy into systems will want evidence that people are good job.
Yeah, I think in terms of the social care field, where me and I tend to spend quite a bit of time, it's like I say, it's definitely it is about looking at family strengths and trying to develop those. Also, there's signs of safety. So you've got where you have the meetings, and it's sort of what's going well for this family, and professionals do that scaling part of it. But it's kind of, I think, like you're saying, Kidge, it's kind of ended there a bit. So it's almost like they're dipping their toes in the water, but they're not ready to jump in yet. And I think that's all around the what if we miss a safeguarding thing? What if we don't ask the right question? I think that's where the fear lies a lot of the time. Yeah.
And I think, it's fair enough. As soon as, obviously risk, safety has to come first. So if I hear people, patients, particularly with swallowing, tell me something that I think that they've got it wrong, I've got to say. And yeah, so I think that obviously as professionals we have to remember. But I think if that is a fear of people, that they think, as I said at the beginning, that we're not maybe doing our job as we should if we're allowing so much space for what the client says or what the client is noticing. But I think if we can keep writing about it, keep talking about it, and telling the story, showing the evidence that we have that it's making a difference, then yeah, it has to kind of, there'll be a tipping point where everybody will be demanding more of this, hopefully.
And I think one of those tipping points, especially in mental health, especially young mental health, is going to be the amount of time young people are kept waiting, and how we can have, even if we meet them for a brief amount of time, but at least get that ball rolling, get some sort of help there, rather than wait until these problems become so entrenched that they just become more and more difficult. So I think you're right. I think there's going to be a tipping point at some stage. So tell us about the training that you do, Kidge. I know you were talking about the training earlier on. So how's that going?
Well, I haven't been doing so much recently. I'm not, as you may have gathered, I'm not a very techie person. So I think online training is, I'm going to leave to people who are sort of more expert than I am. But yeah, I think it's that I was very lucky that, when there is money about, then departments were able to invite me in, and I've done training around the country, and with colleagues in Scotland and Ireland, and that was fantastic. So there are a lot of speech and language therapists out there who know about this, which is something, and I really enjoyed the thing of, again, the because we work so closely with other physios and OTs, and how the physios with their scale work of 10 pains at its worst and 0 is the opposite, how do we incorporate that scale, because they're not, up to now I've not met many physios to let go of that. So Yeah, it was just great hearing about different teams working out, what suited them and with their sort of different clients that came to them. So I think now really I'm sort of really hoping that I'll be able to get back to doing more of the kind of volunteering which I was doing in this community centre near to me, and that's sort of something quite close to my heart. It's actually going back to older people again, who I think often do get left out, and this sort of the light touch, if you suggest to some of them there that counselling, they'll run a mile, but if they have a conversation with this nice lady who quarter of an hour, half an hour, and then in fact usually an hour later we're still chatting, and even people with kind of quite advanced dementia have been talking for an hour, and so I suppose that's again kind of evidence to people that isn't this great that you can bring out the best in people, and yeah, I suppose the other thing is with the frontline counselling that I've been doing, helping people in at the moment struggling, that has been great. I hope to do more of that if this is sort of ongoing, because what they've been experiencing, they're clearly all doing a fantastic job, but it's coming at a cost. And often the pressure, the ongoing pressure, the anxiety that's leading to is really tough. So that's been a real joy, actually, often just by telephone, having these conversations with people. I know various other people. I'm sure it's happening where you are, Jonas. Harvey Ratner did a lovely thing, because he's also doing that, and it's similar stories of just how people have been really anxious, and how focus can so brilliantly in a couple of questions, a couple of sessions, help turn things around a bit.
I've got a question, and it's weird. I should just put it in the private chat. We should ask a question about your upcoming book, and I've been thinking about. I would like to ask you a question about your upcoming book. Because you said you were currently writing a book with Sarah
Northcott.
Sarah Northcott, that's right. Yeah. And that's an interesting collaboration. So I'm wondering, in the work that you're doing now with the book, what are you most particularly inspired by? What are you discovering while writing this book that's engaging you?
For me, it always goes back to people's stories. It's and because I write down people's language comments when we're doing a session. Again, I know a lot of people don't believe in that. I always have done, and I think kind of when you're doing transcripts and when listening again to recordings. Just the subtlety, the detail of when you can sometimes even see or hear things shift, the body language of somebody, and the delight of constantly being surprised by conversations, and how that helps us, talk about how it works, if that's possible. I mean, this book is kind of more detailed than my other one, and it's sort of
In what way is it more detailed?
Well, it's part of a series, and it's kind of breaking down a bit more the kind of different, looking to first session, different kind of stages that you might or might do in a first session. I didn't really go into huge detail in that with the other one, and so this is what we've been asked to do. So. Yeah, I mean, happy to do it and reflect on those details. I think you've been looking at microanalysis, I think, Jonas, haven't you? And
yeah, I'm very inspired by that.
Yeah, and so just enjoying that process, and seeing where it takes us, really.
Wow. Oh, I'm in the front of the queue for buying the book, by the way.
Thank you.
So interesting, because there's a shift kind of going on. There's kind of a shift in the solution-focused world where we're looking more, going slower, even slower, and looking at the level of details.
Yeah.
There's something very interesting coming from that, and we're only just at the beginning. I feel there's so much to be explored. So inspiring to hear that your work that is the direction where you're taking your glasses or your observations. That's really cool.
Yeah. Well, I mean, in November with John Wheeler, I'm doing a workshop which is called Adapting to the New Normal. And everybody said to me, Kidge, that is such a dreadful title. I mean, new normal, everybody knows that. But it's actually what people have been telling me. I mean, particularly the NHS, the frontline staff, they're again and again, if I look through what they said, then, one was saying, I'm looking for glimpses of normality. Another one was saying, I'll be comfortable with this new norm. So it's their words. And I think that's what I keep coming back to, that this phrase new normal is with us, whether we like it or not. And I think, again, I actually chose very carefully the word adapting, because it's not that people are saying they're accepting it. Big difference between accept and adapt. But yeah, certainly at the moment, we have to adapt. And so, yeah, appreciating the kind of nuances of words and respecting that, I think interests me. It goes back, as I say, probably way back to my sort of days of looking at linguistics and speech and language therapy. But I think.
Could you tell me?
Yeah.
Sorry to interrupt. But could you tell me a little bit more about the differences that you feel between adapting and accepting? That was an important shift for you, a difference for you.
Yeah.
I found that fascinating. So what's the difference for you between accepting or adapting?
Actually, I mean, it was something I'd just been writing. It was a conversation about a guy who has a whole lot of symptoms that probably point towards Parkinson's. And he says, I know people want me to accept this diagnosis, and I'm not going to. I said, I don't like that word accept. And I just thought, yeah, there's something about giving up, about accepting. That's just what made me, and that whereas adapting is fitting in with that thing of change, that change is constant, that we are all capable of doing that, and maybe hoping that what emerges from all of this will be something better. But in the meantime, that's all we can do is adapt. I don't know whether that really answers your question. But
I'm very inspired by your answer, so I hope that was great. I mean, it is interesting to pick up words like that and see what the difference is, and yeah, there is. Accepting is a bit of defeat sometimes, right? It is some, adapting. There is a bit more richness. What do you say, Joe? What do you feel?
I was just thinking that maybe a lot of people would think, well, if you're not accepting something that's you medically have, then that would be a wrong thing, a wrong way to view it, because often it's kind of right. I've got this thing, I've accepted it, but I'm going to adapt to it. Doesn't mean that I've given up. Do you see what I mean? Is some people would think, oh, if he's not accepting the diagnosis, then maybe there's something not quite right. I don't know. Does that make sense, Kidge?
Yeah, no, and I mean, again, it's that conversation in the moment. That guy is probably accepting it, but he doesn't just accept. It's that word that bothers him. That I think it was his wife who was saying, "You've got to accept this," and he just wanted to go through that thing in his own way and use his own language. So yes, I agree that that's why he'd come to see me, because it was a problem that he wasn't managing things, and he was going to need to have some conversations about this. But how and when he then maybe later down the line says, yeah, now I accept this, that's you know, I don't know. That's will might or might not happen. In that conversation, that word was the wrong word for him.
Is there any way? Is it? I mean, from that situation, what can we learn as SF professionals? Is there something to be learned? I mean, I always find that the most important things that we've learned in solution-focused language work or practice or whatever word we call it, it's come from a client somewhere. We learned it, and then so why scaling is important. Well, a client taught us scaling. Why is the miracle question useful? Well, because a client suggested it.
Yeah.
You know, why were exceptions a good thing? Well, because clients had them and they offered them to us.
Yeah.
So from this example of a client saying, "Look, I don't like the word accepting. I'd rather work with adapting." What can we learn as SF professionals from that? Is there a lesson for us to be learned? Should we be more adapting to our clients rather than accepting what they're saying, or is there a detail here that we should be adhering to or paying attention to?
I think it's just giving them the space to have to tell you all of this themselves, rather than looking in the referral this person isn't accepting, because they'll know what's going on often. And so asking those best hopes description, it'll come out, maybe not in the first session, but it's asking those questions of what difference will that make? Those kind of questions where people will tell you. I mean, I think it's like, you know, GPs, doctors talk about, you know, having to be a detective often, that, you know, somebody comes with a back pain and after 2 sessions, actually, it's the fact that they're depressed, which is the problem. If we ask the question, you know, so supposing your back pain did get, you know, better, what difference would that make? Oh, well, then I'd leave the house, because I'm not leaving the house at the moment because I'm worried I might, you know, not be able to move in the pain, and you know, that whole thing. So, you know, tell me more about that. You know, you're getting to so it's trusting the client. They will, if you do that, you can get to things much more quickly in a way that's right for them. And so I think it's just a reminder that listen to what they're saying, ask the questions, what difference will it make, and you will. They will tell you, will guide you. Yeah.
I know we have only a few minutes left, but I have one burning question, if that's okay, Joe.
Yeah, go.
You mentioned before how you were dying to go back to community work in a community center somehow. What difference does that make for you? I mean, how does that change your practice or the way you work, or what difference does that make to you? And you know, why is that significant for you? How is that making a difference?
Because I suppose I'm lucky enough now to be in a position where I have the time that I can volunteer to kind of help something that is is close to me in my area in London, it's a fantastic community centre. And so, yeah, I'm kind of using the skills I have, as I say, particularly with, it's not just sort of older people, but there are, you know, those are the people that often don't get the attention that maybe, you know, and they're suffering from sort of anxiety and feeling things are out of control, again, particularly at the moment. It just sort of helps me feel that I'm using my skills. I think solution-focused practice is, you do need to keep going with your skills. You need to having these conversations. So it's one opportunity for me, and I'm very lucky that they let me do it, to sort of keep practicing and, you know, and enjoy being part of that community, because it's great what they do. It really is.
Wow. Thank you, Kidge.
Yeah.
Kidge, I don't know if you can see the question there from Mark.
Okay.
Mark, Matt. Yeah.
The client comes up. Can you read the question to me? Because
sure. I like that distinction, especially if the client comes up with that. So it has meaning for the client. So give the opportunity to ask another question. It is about the client's perspective and language. right or isn't it?
Yeah. Oh, good. Well, I'm glad somebody agrees with me. Yeah.
So that's your so with it in the near future, that's one of your hopes, is the new community work that you're doing. Is there anything else that you still have a burning ambition to do, because you're doing so much already?
Can I ask us a quick question? Sorry, kids. When is the book coming? I mean, I'm front on the line of the queue. I want to know how long I'll be waiting. When's the book coming?
It's gonna be a while, actually. It's sort of deadline is next year, so kind of after that. But no, I mean, in the meantime, just hoping that I love doing one-to-one sessions. I love doing them online. If people contact me, I love doing supervision. I'm involved in a few other things that we haven't mentioned here, but just keeping on doing bits and pieces. And I like the sort of the range and different things, really, that having a bit more time offers me, but definitely keeping on doing it. Oh yeah, definitely. It's that thing, you can't not do it once you know how, and then the opportunity to have these kind of conversations is just wonderful.
Yeah. and that's a very common theme from all the practitioners that we've spoken to. It's once they've started on that solution focused way of working, they couldn't go back to how it was before.
Yeah.
And it's very common. Well, we've had an hour already.
Wow.
So brilliant. It's again fascinating. Always learn new things when we speak. Your passion comes through. It's really brilliant. Thank you so much for doing that. Jonas, thank you so much for being here and supporting and asking such a great question. These are my favorite parts of the week when we meet new people. And I know I've heard of you, obviously, and I've seen you in various things, but to have this opportunity has been brilliant. So thank you so much.
Thank you for inviting me, and I'm.
I would like you to hang on. So we will just say goodbye. Thank you again. Thank you to everyone who's listening. And if you hang on there, guys, we'll be there in a second.
Okay. Thanks, Jonas. Thank you.
Thank you.